Okay, hi everyone. I'm here ahead of our event on April the 30th with Alexis Quinn, and we're going to be talking about pregnancy and restrictive practice. So we'll start with some introductions, really. So over to you, Alexis. Could you just introduce yourself and say a little bit more about why this subject's important to you?
Yeah, thank you. I work at the Restraint Reduction Network, but I'm a person also with lived experience of restrictive practice and during pregnancy. And I had a pretty terrible time in my first pregnancy and ended up being detained on the back of that for 4 years. And then subsequently, when I had my second child, I made sure that certain things were in place, and that the relationships were really positive and good with professionals. And I ended up writing a book called Autistic and Expecting, which covers some elements of restrictive practice in that. So I feel really passionately about it.
Yeah, it's great. It's great to have you here with us. Yeah, I think your combination of lived experience, professional experience, and as you said, some of the intersections between different identity characteristics as well in pregnancy and restrictive practice that we'll cover as well. So just to introduce myself, I'm Vanessa Garrity. So I work as the Deputy Director of Nursing and Quality at Sheffield Health and Social Care Trust, but I have a long-standing interest in perinatal mental health. I used to run the perinatal mental health service in Leeds many years ago. In fact, just before I had my own children, who are now 16 and 14. So it does go back a long time. Since then, I've worked in the system with lots of disadvantaged women during the perinatal phase, and I'm particularly passionate, really, about making sure those women have a voice and that we highlight some of the issues. So today's important to me as a conversation, and yeah, really looking forward to talking to you about this. So, shall we start by discussing why this is an issue?
Yeah, definitely. So I don't know if anyone saw the Guardian article that came out earlier in the month of April this year. But what it showed is that in just one trust alone, under the crisis team in one trust, between 2022 and 2023, 137 pregnant women
Wow.
died. And we also
Gosh.
know, from the mental health data set, that per 10,000 beds, the data was extracted on October 23. There were 909 incidences, median of restraint in mother and baby units. So we do know that this is happening, and we do know, as you were saying, Vanessa, that where there is intersecting identities,
Mm,
that people are more at risk of
yeah.
experiencing restrictive practice in our
Yeah.
services, both in the community and in inpatient settings.
And I guess that's what I'm wondering about when you talked about that 900 and something figure. I was thinking to myself, that's the figure of women who are on mother and baby units. But we know that there is a bit of an inequality that goes on around, women who are very mentally unwell, who are often, deemed as not suitable to be on a mother and baby unit. So I guess it's really important in the future that we start looking at the data of women who are in our mainstream mental health systems, who are on our acute mental health wards during pregnancy, that will undoubtedly be subject to restrictive practice. It's a very, it's very worrying, isn't it? And particularly thinking about how vulnerable it is for women during that period, not just physically, but mentally as well. And of course, all the risks around baby as well.
Yeah, I remember, Vanessa, it was 2 weeks after I gave birth to my daughter that I went into an acute unit and was very quickly transferred to a low secure facility. And not being able to see her, not being able to breastfeed, all of those kind of things, and have that kind of nurturance and that sort of early attachment with her, is really difficult. And it's something, I mean, she's 12 now, but it's something that I reflect on, even now. So I
Yes.
think that sort of early attachment and that kind of trauma, that's quite difficult, to quantify. I think the lifelong impact of that for both the birthing person and the baby.
Yeah, well, it can have absolutely devastating lifelong impact, can't it, on the relationship and so many other factors. And I think that's really interesting what you mentioned about breastfeeding there, because that's something I saw when I worked with women who were perinatal in prison, women who were not given the right to breastfeed, for example, which obviously is a human right. And I guess for people who work in mental health who don't work in the perinatal area, they might not think about a woman not breastfeeding as being a blanket restriction. Because of course, you know, working in adult mental health, the focus is always on the adult, but actually, you know, thinking perinatally is about thinking about mother and baby, isn't it? So for me, I know when I worked in perinatal, there were two aspects of it. There was the working with women and supporting women, but there was also actually, as you say, looking at the relationship between mum and baby and how you can help facilitate that bond and attachment, which, you know, as you say, is it's hugely important, isn't it? And I wonder as well, and I'd be interested in your thoughts on this, whether we make assumptions about parental responsibility as well for vulnerable women, and whether that's partly why this happens as well. What are your thoughts on that?
Yeah, it's really interesting. As soon as I got pregnant with my son, which was a planned pregnancy, you know, and I was in a very sort of different place. It was 5 years on from my discharge from hospital. I was immediately sort of social services involvement, you know, and I was working in a professional role. You know, I was at university as well, you know, studying a master's degree. And I always felt there was this kind of underside of threat, you know, about social services and about even things, Vanessa, like visiting, you know. And I think this is, you know, I know it's something we're going to talk about later, but the different types of restraint, because of course
Yes.
you've got, haven't you, that environmental restraint where you're locked in somewhere, or you're maybe with your baby or you're away from your baby.
Yeah.
You've got this scrutiny on you, this surveillance that mothers wouldn't have, you know, if they were at home, you know, where they might be having baby blues, they might be upset, but all of that comes with this kind of value-laden judgment. Oh, you know, Alexis is upset, you know, what does this mean? You know, it's kind of medicalized, isn't it?
Medicalizing human emotion. Yeah.
So I think there's that surveillance, but I also think there's this, like, it was like my daughter was weaponized. It's like, you know, if you do this, this and this, you can see your daughter.
Yeah,
And maybe I
that's
didn't
awful.
agree with that, you know, and of course it's right and proper that safety and risk, you know, of course that's foremost. And I wanted that for myself and also for my daughter. But there was a sense of this kind of psychological restraint element. And what I felt, you know, is that where there were blanket restrictions around visiting, which was usually in the evening when she was asleep, for instance, and there was no sort of adjustments made for that, that's what used to get me very, very distressed, right?
Yeah.
So the sort of the surveillance, you know, the blanket restrictions, the psychological restraint, as you say, you know, parental responsibility, so that kind of cultural restraint, like you're autistic, you know, can you really manage this?
Yeah.
Leading to distress. And then of course came the physical, the chemical restraint, you know, the seclusion, the mechanical restraint, for me, anyway. So I think it can escalate. It's really important to attend to that softer, if you can even call it that, type of restrictive practice.
Yeah, and I think there's a lot that you've said there about trauma, isn't there, as well? You know, we talk a lot about being trauma informed, but I know again, and I'm thinking back a long time ago, women who used to come to the mother and baby unit where we would be told, you know, this woman is really acutely unwell. I don't think you'll be able to support her on a mother and baby unit. She's trying to abscond, she's aggressive, she's, you know, this, that, and the other. She's quite disturbed. And actually, what we would find is that we were talking about women who were on, you know, acute mental health wards who'd been separated from the newborn babies. And what we often found is once the mum had been reunited with the baby, although the mum was still unwell, a lot of it was communicating distress around, you know, the separation. So I think it's also, you know, how we kind of view sort of therapeutic risk taking within mental health and person-centered care, isn't it, really? It's about kind of understanding how much of that is, about mum and baby.
That sort of othering, though, that dehumanization, that this thing
Yes,
wouldn't be
agree.
upsetting, that it wouldn't be upsetting that I couldn't see her at visiting, that it wouldn't be upsetting that if I didn't take this medication or comply with this request, that I then couldn't see my daughter. You know, it does feel quite dehumanizing, you know, like we're not like other people. I think any mother separated from their baby will be very, very distressed.
Yeah. Well, I guess for people listening as well who are mums, and, you know, speaking as a mum myself, you know, it took me a long time to be separated from both my babies at all. You know, when I think about, you know, going back to work and, you know, coming to the end of my maternity leave, you know, going to look around nurseries, and we're talking about when my children were about 12 months old, it was a very difficult experience, you know. And so, you know, separating mums when they've just been through, you know, the trauma of birth and that kind of intense feeling, you know, that you're holding your baby in your arms and then being separated, you know, we really need to think mindfully about this. And I think up until now, it seems to be an issue that's been very specific to specialist services, you know, women who reside within the perinatal mental health system. And yet we know that lots of women are not in the perinatal mental health system. They're in our acute wards, and they're in our communities, and they're in our crisis teams, you know, receiving support. And, you know, as I've said, some of these women are, you know, in prison as well. You know, we've got lots of women in the criminal justice system that have been criminalised, often, you know, due to poverty and, you know, multiple disadvantage, drugs usually related to trauma. And I think it's also about reaching out to those women, isn't it, as well, because there's still women in our mental health system, regardless of where they are. So I think that intersectionality of, you know, injustice and disadvantage is really important. And as you mentioned, and, you know, I think we should touch on that about neurodiversity too.
Yeah, for me, I think there's something really important here about being super proactive with this group of people, because I think, you know, as soon as that distress kind of escalates and you need to introduce, you know, pharmacological intervention,
Yeah,
you know, I didn't want to take it because I didn't want it in my breast milk.
no, of course.
You know, and I was really worried about that when I had my son. You know, are they going to make me, you know, take some medication? You know, and
yeah,
you know, when you're pregnant, you know, there's so
yeah,
much emphasis, isn't there? Don't take this drug, don't eat cheese, don't
yeah,
eat, you know,
exactly.
whatever it
Don't have
is. And then we're
alcohol,
like,
drink
have all these
coffee.
antipsychotics, you know,
Yeah,
calm
yeah,
down.
yeah.
And that scrutiny, you know, can feel really, really stressful. And certainly for me, like, I felt like I didn't want to engage. Like the second time I was like, you know, let me really try and think about how I have these relationships and what these relationships need to look like and who I'm going to let close to me, you know, who's going to be an advocate for me. So I think for people listening, I think we need to really try and, you know, build those relationships and form a relationship where the person feels that you're on their side and you enter into their world and you understand their different frames of reference, because it's only then that you're going to be able to work really proactively with somebody and hopefully, you know, stop those more obvious, damaging, trauma-inducing types of restrictive practice. And be an
Yes.
advocate, right? Be an advocate for that person, for social services, be an advocate with the midwife,
Yeah.
be an advocate with the health visitor.
Yeah, absolutely. And again, there's so much in that, isn't there? And, you know, going back to what you were saying about medication as well, it's about having you know, sensible you know, conversations with somebody who's qualified, because, you know, it's about risk benefit analysis, isn't it? That, you know, some of the medication you have doesn't have damaging side effects in terms of the baby, but will, you know, allow women to be able to, you know, care for their baby. Whereas, you know, equally on the other side, some medication, you know, you wouldn't want to take during pregnancy. So it's also about, if we've got women, you know, who are in our mental health system, having access to, even if they're not under perinatal mental health services, having access to that expertise around prescribing medication so that they can make informed choices about what medication they want to take for themselves and the baby, and feel reassured that actually not all medication is bad, that it might actually be a real protective factor. And being able to make those decisions feels, you know, really important. I think a lot of what we're talking about as well is about, as you've said, working with women from the early stages. So, you know, if women have got a history of, you know, serious mental illness, you know, complex trauma, serious, you know, levels of trauma, then it's about recognizing that in the early stages, isn't it? And just being person centered and, you know, working with the woman to think about what might help and what might not help, and, you know, allowing a woman to feel in control as well of her own pregnancy.
Yeah, and I think, you know, there's something about as well, you know, this kind of like outreach, you know, because I know certainly I was like, I don't want anything to do with you, like go away, you know, because it just got very adversarial. And just understanding that people, especially, you know, perhaps from, you know, marginalized backgrounds who've had difficulty with services, that they might not be like super inclined to engage. And that doesn't mean that they don't want the help. Like I really did want it. It was just really difficult to trust. So it's about, you know, you've got to be different than what the person experienced before. It's not like you come to this appointment and if you don't, you're discharged, or we're not going to ring you, you know, we're not going to step out. So I just think there's something as well about, you know, understanding, as you say, people's trauma histories, you know, complex PTSD, or however we want to refer, you know, to that type of relational trauma that's happened before. But we can't have those conversations about medication. You know, you can't have conversations and, you know, perhaps de-escalate distress in inpatient settings if you don't have those relationships. It's not going to happen.
No, it does come down to person-centered care, doesn't it, really, and having empathy and, you know, being able to forge that connection, which I've always argued that, you know, they're the most important aspects as a mental health nurse. I think that's where, you know, the skill is, but often it's quite difficult to articulate. But, you know, it is what makes a difference, isn't it, time and time again to people, and, you know, meeting people with that compassion, empathy and care for their situation, and being able to help women. And I think, you know, as a mum, being able to kind of, you know, step into somebody else's shoes and think, well, I'm a mum, you know, how would I feel if that was happening to me, and what would I want, you know, and being able to advocate, you know. And sometimes it can be really difficult, can't it, advocating when you've got a system that, you know, are really strongly telling you to do something else. But it's just so important, isn't it? And, you know, you talked about children's services. I think that's another area where, you know, we cannot make assumptions that women can't care for the babies because they've got a history of, you know, serious mental illness, a history of drug and alcohol use, you know, learning disability, you know, neurodivergent condition. We can't make assumptions, and we can't take a blanket approach. We need to, you know, work with the individual and look at what support we can put in place to help people.
Absolutely. Well, I think we should leave it there. Thank you, Vanessa, for this opportunity.
Yeah, no, thank you for the opportunity of talking to you. Actually, it's been a really great conversation, and I think there's lots to do going forward. But hopefully, you know, what we've talked about today will give people some thoughts to reflect on and think about how we, you know, take some of this forward. Thank you.
Start of a conversation.
Yeah, exactly.